So let's proceed to the selected abdominal and pelvic abnormalities. I've taken this, the main source was the book, and as well we have a mini ASCII file for surgery that have certain pictures that are not, or certain topics that are not that much discussed. So I just included 1 or 2 slides for each subject. Okay, so we will start with the calcifications. Now we said that on supine X-ray, on supine abdominal X-ray, on the X-ray in general, the first X-ray we look at, which is when the patient is lying down and we are giving him X-rays from above, we can identify organomegalies, we can identify the gas pattern, and we can identify calcifications. From these calcifications, we can see a thing called phlebolyth. Now, phleb means vein, and lith means stone or calcification. So phlebolyths, these are more common in the pelvic of females, and they are calcified thrombi in the veins. So how do we distinguish between these calcifications, for example, and the calcifications in the collecting urinary system? We see that they are including a nidus, which is more lucent, which is more black, if we can say, more black than the surrounding phlebolyth, or the covering of this phlebolyth. So this phlebolyth, or this calcified thrombus, we will have it as a surrounding opacity and a central lucency. So this is the first calcification that we might see, and it's in the pelvic veins in the age group of women, in women, and the age group of most likely when you grow up in age more. So in elder females, you will see it more likely than the other younger females. The other classification that you might see, and it has more of a pathologic diagnosis or a pathologic prognosis or significance, is the porcelain or calcified gallbladder. Now, porcelain, because when you excise it intra-op in the when I want to excise it during surgery, when I open up the abdomen of this patient, it will look like a porcelain, the color of the porcelain, which is this shade of blue. So this porcelain calcified gallbladder, it indicates that this bladder was inflamed and irritated multiple times. So when I have multiple bouts of cholecystitis, which is an inflammation of this gallbladder, when I excise it intra-op, I will see it as looking this in this color, and when I look at it on X-ray, I will see this rim of calcification. Now, there is an important thing to know. When I have a tube, like the cystic, like the gallbladder, or for example the arteries, the calcification pattern is linear. So as you can see here, it's a linear calcification along the wall of this gallbladder. Okay, so this is porcelain gallbladder indicating recurrent cholecystitis. Okay, we can see other calcification, which is the calcification that indicates the chronic pancreatitis. This chronic pancreatitis, the bouts, when I have multiple bouts, fat saponification happens in this pancreas, and I have entrapment of calcium. That's why one of the signs on CT, I can appreciate it more on CT scan than X-ray. I have multiple foci that are hyperdense, or here I have multiple opacities on the shade, over the shade of the pancreas. When I see this, or I see this, now this patient, I'm sorry, Edwin, because you weren't on the previous sessions. I will just briefly explain this CT. Now, this CT scan, as you can see, this is a thing filled with air, and here I have an opacity. Here, this is opacity of the oral contrast. The oral contrast appears as hyperdensity. Okay, so here I have the stomach shade, here I have the liver shade, and here I have the spleen shade. Okay, and here is this this kidney. Because this is not given IV contrast, I'm not giving any contrast in the veins, it's not that much apparent or appreciated, only oral contrast is here giving. So this shade is here the shade of pancreas, or this is the organ site of the pancreas. That's why these are this is the sign of chronic pancreatitis, which is the calcifications. Here we can see that this patient, this is the femur of the patient, and this femur is somehow cut, it's not continuous. So this patient is having above knee amputation. This means this patient suffered from, for example, diabetes, and he had a gangrene, for example, or diabetic foot complication, and they had to amputate his foot above his knee. So this is a femur, and as you can see here, we have a vessel disease. And as I told you, it is a tubular, since it's a tubular structure, this vessel is undergoing a calcification that is linear. So this linear calcification here is indicative of severe atherosclerosis. And here you can see the surgical clips. These surgical clips are after the surgery. So they are indicative of the surgery that has happened. Here we can see another patient. He is having this atherosclerosis in the wall of the aorta. So this is here the IVC, and here is the renal vein here, and this is the left renal vein over here. And we can see that this tortuosity, or this tortuous structure, is the splenic artery. So I have here calcification. Regardless if you can link things together, the main thing I want to say is that we have calcifications here in the arteries that are indicative of the atherosclerosis, or this this disease that has happened to the arteries, and the appearance of this calcification in the aorta or any vessel as being a tubular structure is linear like. Now here is an interesting type of calcifications, which is calcified rib cartilage. Now this calcification of the rib cartilage, it is a process of aging. But what's interesting about it, that it takes first, it takes the it comes with age, and it takes the arc of the cartilage in the ribs, and it has a forensic value. So depending on the type of calcification, depending on, sorry, the pattern of calcification of this rib cartilage with time, they can distinguish if the dead person was a male or a female. So this is a very interesting thing regarding the calcification of this rib cartilage. If I had a calcification of this rib cartilage, I can tell whether this is a female or a male, depending on how this calcification appears. So this is very interesting. Okay, so let's go to the other section, which is organomegaly. Organomegaly means the occupation of space by this increased in volume or increased in size organ. How does it appear when I assess for any organomegaly on the abdominal X-ray? I either look at the displacement, I either look at the shadow of the organ gets increasing, and if I had things of different shades, I will have the edge appearing, or I will look at the displacement of the gas pattern, which is the large bowel. So here, let me show you something. This is the shadow of the large bowel here. And this is also the shadow of the large bowel. It should be like that. So if I had to compare between two pictures, I want you to look at this one and I want you to look at this one. This shadow of the small bowel, and here the stomach, and here the large bowel, as you can see, is going up and is not occupying, okay, the right upper quadrant, but it's way above this shadow. Now, this is a patient who has hepatomegaly, and because he has hepatomegaly, this gas pattern is being displaced from its normal site, which it should be in. So this patient is having hepatomegaly. And how did I say that? Because this normal pattern, or this gas pattern, is being displaced more towards the other side. So this is how I say that I might be having this hepatomegaly. And to better appreciate it, actually, sometimes I cannot appreciate it on X-ray. So the better modality to appreciate is both clinical examination, if I do the clinical examination, and the CT scan. It's better to tell me if I have a true organomegaly or not. But as you can see here, this is scout, which is supine. As we said, supine and scout are interchangeably used. So I either have this, I either have the displacement of the gas pattern, or I have the clear increase in this soft tissue density from here to here. So this is the liver edge, and from here, and I go all the way down here, and I go all the way up to here. So I see that this gas pattern is being displaced. So I know that this might be a hepatomegaly. Okay. when I talk about the splenomegaly, which is the other way around, now the splenomegaly or the spleen enlargement is pretty interesting. Why? Because you might have heard the girls with us from the 4th year, they heard in the introductory course, because when I examine for the spleen enlargement or the splenomegaly, the spleen enlarges diagonally rather than going downward. So it doesn't go down, it goes rather diagonally. So I start the physical examination looking for splenomegaly from the right lower quadrant. Now, why is that so? Because there is a ligament between the colon and the diaphragm, which is called phrenocholic ligament. When I have this phrenocholic ligament, this spleen, which normally should not be going over, now this is the shade of the 10th rib, the 11th, and this is the 12th rib. When I have this normal spleen, it should be like this. Here, it should be the normal shade of the spleen. But this spleen is going past the 12th rib. When I have this shadow of going past the 12th rib, and this shadow is going like this diagonally, it's not that close to the vertebral column, I will say that this is the shadow of an enlarged spleen. This phrenicocholic ligament prevents the more downward placement of this spleen. That's why it rather goes and grows diagonally rather than growing vertically downward. Okay, so when I examine for splenomegaly, the next time you examine for any enlarged spleen, you will know why we examine it in a diagonal pattern or diagonal way, because it grows diagonally because of this phrenicocholic ligament. So here I have this enlarged spleen over here, and the liver is going normal inside, and this is all the pattern of the large bowel going downward and being displaced here because of this enlarged spleen. And this is a patient that has an upright abdomen, and I can't here appreciate the gastric bubble because of this enlarged spleen that is occupying this space. Okay, as you can see, how did I determine the lever edge here? Because I have this peritoneal fat that is giving me a distinguished liver edge that I can see here, and the liver border here that I can appreciate. That's why I can determine that, yes, this is the liver shade, and below it, this is the pattern of the large bowel, because it has air in. So this is regarding the splenomegaly. I wanted to look at the enlargement of the kidney. I will go just one section up, one slide up. So this is the appearance of an enlarged kidney. As you can see here, now these are the iliac crests. As you can see here, this enlargement goes downward and it's vertically, and it's displacing all these bowel and all the gas in, whether it's small or large bowel, it's displacing it to the other side, and it's growing vertically. When I see this appearance of this soft tissue mass, displacing, and it's close to the vertebral column, and it's displacing the bowel to the other side, if it was that enlarged, I will say that this is rather a kidney, not a spleen. And when I look at this same picture at CT, this is a coronal section, this is a huge renal cyst. Why? Because this patient has taken an IV contrast. This is the small, very small remnant of what is left of this left kidney. So this is the left kidney over here. As you can see, it's very pushed by this big left renal cyst. Here is the spleen pushed upward, and this patient is given oral contrast. Why? Because you can see all these loops of small bowel filled with oral contrast, and you can see the cortex of this kidney filled with contrast. So I have given this IV contrast filtered with by the kidneys, and I have this oral contrast over here, so oral and IV contrast. And this, why did I say, for example, this is not a tumor, this is rather a cyst? Because I am having this cyst not taking any IV contrast. So when I have this fluid in it not taking any IV contrast, I will say yes, probably this is a cyst rather than, for example, a tumor. I want you to look also how this liver is pushed by this enlarging cyst. So this is how it looks when I am assessing for an enlarged kidney. When I have enlarged kidney, I want you to look now the difference between the kidney enlargement and the spleen enlargement. As you can see, this spleen is already going this way, but this kidney is moving down, and it's moving vertically, and nothing is stopping it because it's retroperitoneal inside and doesn't have any ligaments associated with it to stop its growth vertically, while this is having, as we said, the phrenicocholic ligament preventing its downward growth. So it's growing obliquely. So as you can see, this is the main difference. First, it has a more closer shade to the vertebral column because it's closer than the spleen. And second, it's growing vertically rather than growing obliquely. When we move on to the pelvic structures, I want to point out a very important thing, or two important things. The first one is that this picture is in a male, and this picture is in a female, and this is what we have talked about yesterday, which is this line of fat that is surrounding the bladder. Now, how do I distinguish the bladder from the uterus? This is the uterus above it. The shade, because these are two soft tissue densities. Because of this fat, I can distinguish between the borders of both of them. This is an enlarged bladder, and pseudo is occupying and displacing the bowel upward. So this is an enlarged bladder. Now this is a male. When I see an enlarged bladder in a male, especially if he is an elderly, I will say that most likely I'll be thinking of benign prostatic hypertrophy, which is BPH. When I have this enlarged shadow, I will say that it's most likely not other than, let's say, the first thing that I will say that it's probably an enlarged bladder. And as we said that in males, the sigmoid colon is above the bladder. So here we see that because this bladder is enlarged, this fat line is not there anymore because everything has been displaced. So the anatomy is not as we used it to be. So here we have this fat line over here, and here we have this increased shade of the uterus. So this uterus is enlarged. So here we have the bladder enlargement. Here we have the uterine enlargement. And how to distinguish between them? The preservation or the absence of this fat line that surrounds the bladder normally. Okay. So we have ended talking about the organomegaly and the calcifications. Does any one of you have any questions before we proceed to the bowel obstruction? Okay, so let's continue to the bowel obstruction. A bowel obstruction is defined as the cessation of the movement of these bowel at a certain point. So it's either mechanical, a true obstruction, or it's functional. When I talk about, when I talk about the functional obstruction, it's not a true obstruction, but it's a cessation of the movement of these bowel. So I have a functional obstruction, and it's either this functional obstruction, it's either localized at a certain point, or it's either a full functional obstruction of the bowel. When I have a full functional obstruction, the bowel all in all is not moving, I call this an ileus. So ileus is a functional obstruction, if I may say, of the whole bowel. Why does that happen? The most common cause of ileus is post-abdominal surgeries. So if I have a patient that has been manipulated, that his abdomen has been manipulated by this abdominal surgery, this will irritate the bowel wall. So this patient will end up with ileus most likely. So that's why we do not discharge any patient post-abdominal surgery before he's passing at least flatus or stool. So to make sure that the bowel has regained its movement again. The most common cause of electrolyte imbalances causing this functional obstruction is hypokalemia, the decrease in potassium levels. That's why this is a very important surgical cause of ileus. So this is the functional generalized ileus. All the bowel is not moving regardless of it's a small bowel or large bowel. This is called ileus, okay? When I have an obstruction, when I have a certain obstruction at a certain point, this is called mechanical obstruction. This means there is a blockage of the continuation of the peristalsis. Then now the most common cause is hernias, and after that, hernias if I don't have any operated abdomen. If I have an operation that has been done on this abdomen, the most common cause of mechanical obstruction is adhesions, which are adhesions post-surgery. As you can see, it causes obstruction, either full obstruction or partial obstruction. We will look at it in the upcoming slides. So if I have a functional obstruction, which is not a real obstruction, it's rather a cessation in function of certain bowel, in certain part of the bowel. If I have a certain certain loops that have cessation in the movement, I call it a functional obstruction. A localized functional obstruction or a localized ileus. This localized ileus is or is defined as having loops of dilated small bowel loops, which are not changing in shape. If I did a patient, or if I filmed this patient, or I have done an imaging of this patient in multiple positions. For example, this patient having a supine abdomen and then a prone abdomen. So once I laid him on his back, once I laid him on his abdomen, and this appearance did not change. If I have an unchanged appearance through these both images, I will say that yes, this might be a functional obstruction. Now, how do I define a functional obstruction? Functional obstruction happens because I have local irritation, and most commonly if I have an inflammation of a nearby organ. For example, this patient is having pancreatitis, is having an acute pancreatitis. These bowel loops on the left upper quadrant are irritated, so they got dilated and filled with air. These are small bowel loops, and when I take a prone image, these bowel loops did not change in their dilatation. So when I see loops of dilated bowel loops on supine and prone, or regardless, two images, they are not changed and they are in just a certain place, I will say that these are sentinel loops. They're called sentinel. Sentinel means the guard. So these are sentinel loops. They're guarding and they're indicating an inflammatory process that's happening, because sometimes the history of the patient is very vague, so I don't know what's going on. But when I see the x-ray and I see the sentinel loops, I say, oh, okay, most likely I have an inflammation or a local process that is beside these loops and cause them to cease from from having the normal peristalsis, so they are now dilated. Now, what distinguishes this from a mechanical obstruction? There is no obstruction site. They are only not moving. So here in the rectosigmoid area, which should be having gas, because I still have a passage of gas, but these are not moving. I still have passage of gas, so I'll still be able to see the rectosigmoid area having gas in. So this is a gas in the rectosigmoid area. So having a dilated small bowel loops in a certain place with preserved rectosigmoid air bubble, I will say that this is a localized ileus, and these loops are called sentinel loops. Now, if these sentinel loops were here, for example, in the right lower quadrant, what do you think the inflammatory process will be if I saw these loops here in the right lower quadrant? What do you think the pathology might be? Which type of inflammation it might indicate? Excellent with that. So it will be appendicitis. For example, if I said the left lower quadrant, what do you think the inflammation would be there?
Where?
In the left lower quadrant here.
Maybe the diverticulitis or...
That's excellent. So diverticulitis. So how about this one, the right upper quadrant? What do you think the inflammation?
Cholecystitis. Acute cholecystitis.
Yes, exactly. Cholecystitis. So the most common inflammations regarding the quadrants, here cholecystitis, and here pancreatitis, here appendicitis, and here diverticulitis. These are the most common to cause sentinel loops when I see them on X-ray. When I look at these, this is a patient who is having pancreatitis. This is the pancreas and it's having very dirty. Now here is the continuation of the small bowel, but here you can see a distorted appearance of the pancreatic tissue, with a distortion also of the normal peritoneal fat. When I see this dirty fat planes, we call it in radiology dirty fat planes. When I see these dirty fat planes with this appearance of the pancreas, and these small bowels dilated more than their caliber. The normal caliber is supposed to be 2.5. So almost, if I saw them more than 3 centimeters, almost, I would say that these are dilated. So when I see this appearance, this is a localized ileus. Now this is the here, this is the kidney, and here is the appearance of the kidney. So this patient has been given oral and IV contrast. Okay. So this is regarding the functional ileus, or the localized, the functional ileus, which is localized. Here, as you can see, this is a supine abdomen. This is an upright abdomen. We can see that these bowel, we cannot distinguish, are these small bowel, are these large bowel? For example, I can't say that this is a feces, this is fecalized material in a large bowel, so this is a large bowel. But as you can see, we do not distinguish here. We cannot distinguish here whether it's a large or small bowel. When you see this diffuse pattern of enlarged small and large bowel, this is a functional generalized ileus. This is the generalized ileus. But here we can say that, okay, I am looking at this rectosigmoid area over here. This air is still preserved. The air in the rectosigmoid area is still preserved. That's why I say, okay, this is rather a generalized functional obstruction, or an ileus, not a mechanical obstruction, because I can still see this rectosigmoid area. Now, this is very important. Here, you should distinguish between two important things. If I have an early mechanical obstruction that is distal in the colon, I might be able to see this pattern of the preserved rectosigmoid area. I will show you in a bit. So if it was an early obstruction, I might be able to see this, but there is a very important thing. In the when I show you the mechanical obstruction, this is very important to know if the ileocecal valve is competent or not. If the ileocecal valve is competent, it will prevent the return of air or any content from the colon to the small bowel. So the small bowel will not be dilated if the large bowel is dilated in a mechanical obstruction of the colon. But if I had an incompetent ileocecal valve that allows the passage, the retrograde passage, I will be having a thing that might be looking like this. But the clinical picture on its own, the other indications also will help us to distinguish, is this an early mechanical obstruction in an incompetent valve, or it's a generalized ileus. Generalized ileus, probably you will see a patient that is telling you that he just recently had an abdominal surgery a day or two before his coming to the ER. So we will have also a supporting history and also supporting physical examination. We will start now by talking about the mechanical obstruction. Now, this is an important picture because you will probably see it in the many OSCE files a lot. So this is the appearance of, I think we call it a step ladder sign. If I had a mechanical obstruction, this patient had a carcinoma of the colon and obstructed the ileocecal valve. So the ileum and the jejunum are dilated. Because the ileum is localized over here in the right lower quadrant, and the jejunum is in the left upper quadrant, when I have an obstruction and I position the patient so the patient is standing, I will be having an air fluid level between the air which is dilated in this small bowel and the fluid which is succus entericus, or the chyme, or the fluidy material in these small bowel. This appears as called step ladder sign. This step ladder sign that is indicative of mechanical small bowel obstruction. These two sentences I want you to bear with, to remember very carefully. If I have a step ladder sign in a dilated bowel and dilated bowel loops and air fluid levels, these are air fluid levels in dilated loops, in an erect abdomen X-ray, which is a patient who's standing. How did I know that this is erect? abdominal X-ray, because this is the gastric bubble over here, and it's just below the diaphragm. When I see that I have an abdomen X-ray erect that is having multiple dilated bowel loops that have air fluid levels, this sign is called the step ladder sign, and it indicates mechanical small bowel obstruction. Also, when I have an obstruction, I will not see, if I go down, these are the iliac crests, if I go down, I will not see the rectosigmoid area filled with air. So the absence also of the rectosigmoid air bubble is also indicative of this mechanical small bowel obstruction. Okay, here when I put the patient on his back and do an X-ray for him, I will see the appearance we talked about, which is the valvulae conniventes. These valvulae conniventes means all these continuous lines that are indicative that this is a small, these are all small bowel loops, and this is the large bowel here.